Good evening, everyone. You are in listen-only mode for the beginning of this program. This is being recorded for future use. Please type any questions that you want to be answered into the chat box. Welcome and happy Martin Luther King Day. Thank you for attending tonight's webinar, where we aim to highlight the importance of making your healthcare decisions, screening for cancers, and immunizations to preserve our individual health and to improve the health of our community. My name is Ruth Price Rollins. I am the president of the Greater Cleveland Alumni Chapter of Delta Sigma Theta Sorority Incorporated. It is my privilege to welcome you to tonight's webinar. We hope that this webinar provides you with information to begin a conversation about advanced directives. And I want to thank the Physical and Mental Health Committee for providing this opportunity to us this evening. And at this point, I will turn it over to our Physical and Mental Health Committee Chair, Kalia Fisher-Grace. Kalia?
Hi, good evening, everyone. It's my pleasure to introduce our speaker, my colleague, Ms. O'Mary Dwyer. Ms. Dwyer is a clinical ethicist at University Hospitals and a clinical assistant professor of bioethics at Case Western Reserve University. She has clinical experience, training, and expertise in the practice of clinical ethics. Her background is in law and its intersection with medicine and philosophy, with specific training in health law, elder law, adult and pediatric clinical ethics. Ms. Dwyer's research interests have pertained to the various issues that arise in adult and pediatric clinical ethical consultation. She has been involved in thousands of ethics consultations since 2007, which has provided her with the groundwork to see how broad policies, laws, and the gaps that exist affect bedside clinical care. Her involvement in these cases has prompted her to perform research which could be used to develop effective guidelines and frameworks to improve clinical decision-making, team familial discussions, and identifying the limitations that exist in clinical care. We thank you all for participating this evening, and with that, I turn it over to you all, Mary.
Thank you so much, Kalia, and thank you, Ms. Price Rollins, for having me, and thank you everyone for joining us tonight. So we're just going to dive right into this. So I want you to keep in mind while we're going through this talk, situations that you've dealt with when you're thinking about your health or the health of your loved ones. So right off the bat, let's start off with the case. We have Ms. Jacobs. She's a 47-year-old woman who was diagnosed with lung cancer. Recent scans show that she has metastatic disease that has spread to her brain. These mets have caused occasional confusion and disorientation. The medical team has asked Ms. Jacobs to call her family in order to have them assist her with making medical decisions. She is a widow and has a total of 5 adult children, 2 from her first marriage and 3 from her second. She has very involved siblings, a brother and sister. Her brother attends all of her doctor's appointments with her. Now, hopefully this scenario does not sound unfamiliar to folks. Unfortunately, this is a situation that comes up a lot, and we, as a medical team, sometimes have to deal with these questions of, if Ms. Jacobs loses capacity, who amongst her family members should act as her surrogate decision maker? Does anyone want to take a wild guess as to who could possibly act as her surrogate decision maker, given this presentation that you've heard so far? And you can use the chat function to make that guess. And believe me, there are no wrong answers here. Her brother, okay. It's a good, whoever she appoints, anyone could be. Okay, immediate next of kin. All right, so great answers. We're going to get into the complexities of those answers and which one of these family members it could possibly be, because depending on the scenario, all of these could potentially be the correct answer. Okay. Another question that I know is very applicable in a situation like this. If her cancer continues to progress, what should be the goals of her care? Or if she loses the ability to breathe on her own or to eat safely, should she be placed on a ventilator or a feeding tube be placed? These are big, weighty questions that come up all too often. And unfortunately, myself as a clinical ethicist, I get called into situations where unfortunately the patient and their family haven't thought about any of these questions. And so we, the medical team, as well as the family and the patient, are kind of left scrambling to try to figure out who should be doing what and what the decision should be made in the first place. So I'm hoping that in this talk will help navigate not only your healthcare, but also the healthcare of your loved ones too. Because I've seen all too often situations where families are agonized by these decisions because they didn't take the time to think and talk to each other about what they would want in case something happens. Okay, so for our talk today, we're going to focus on two main things. One, why are advance directives important? And two, how to inform family and to document care wishes. And again, I want you to, throughout this talk, not only think about your own health, but also the health of your loved ones, because it's all intertwined. Okay, so why plan ahead? I know it's a scary thought for a lot of folks to think about what could happen in the future. You know, sometimes we're even a little bit superstitious, saying to ourselves that if I were to even let my mind go there, I may be bringing on bad things in my life, that I could cause something to go wrong. Unfortunately, that is a hard, I guess, superstition to kind of counteract. But again, when we're thinking about healthcare decisions, you have to contemplate what type of life you would want to live in case anything were to happen. And honestly, it ends up actually being a gift to your family, because I've seen too many times where unfortunately families sometimes can be damaged dealing with situations like these. Instead of bringing the family together, it ends up pushing them apart. So I'm hoping that we can avoid that for all of you. Okay. So as a medical team, we always want everyone working together. We want the healthcare working with the loved ones of a patient. And of course, we want to keep the patient as our focus. And in order to keep the patient as our focus, we have to keep everyone on the same page. Everyone needs to know what's going to happen with the patient, what decisions need to be made, what are the priorities. These are all things that have to work seamlessly together in order to provide good care to a patient or to a loved one. Okay, so let's face reality. Unfortunately, everyone in America dies. And that's not just true in America. That's just unfortunately the human race. We all die at some point. But specifically, dying in America can be highly, highly medicalized. To the point that actually a lot of folks are not comfortable with how medicalized it can become and what it looks like. Unfortunately, the dying process can also be very prolonged. It can be expensive, and often, all too often, it is out of sync with what people's preferences actually are for how they would like to deal with their end of life or any other healthcare issue that may come up. Okay. Now, there have been lots of studies that kind of illustrate this reality. So if you looked at Medicare patients with chronic illnesses, 28% of them died in the hospital, 17% of them died in the ICU, and a good majority of them, or a good bit of them, spent about an average of almost 11 days in the hospital in the last 6 months while they were dealing with a chronic illness. Now, when you're looking at patients with cancer, nearly 30% die in the hospital. 61% of them are hospitalized in the last month of life. And actually, we know that this is counter to what a lot of people want in their priorities when they get to that stage of their life. So why does this keep happening? Okay, so we know what most people prefer. They want to die at home with their loved ones, okay? But unfortunately, that doesn't happen. They want to avoid a prolonged dying process that exhausts resources. They don't want to be in pain. They don't want to lose their ability to think. They still want to be independent, and they don't want to be in a nursing home. I don't think any of these wishes or preferences are a surprise to anyone. I think that's a pretty, like this list is pretty universal when you ask most people across this country. Okay. And yet, looking at the trends over time, folks still die in a facility of some kind, either a nursing home or a hospital. Rarely do they get to die at home. Okay. When people think about dying, unfortunately, these are some of the things that people focused most on. Family money won't last, the money won't last, or that there'll be a burden upon their family. And one of the burdens that people often, I think, overlook is having to step up to make tough decisions. Unfortunately, we know that a lot of families, because they don't talk with each other openly about what their wishes could be, this can inadvertently become an extra burden upon family members that ends up making them carry this heavy weight of, oh no, did I make the right decision for my loved one? But if you talk about it ahead of time, hopefully we can avoid that burden for everyone. Okay. Sometimes people think about circumstances that could be worse than death. Some people think, death in and of itself is the worst possible thing that could happen for them. But others, in fact, majority of others, in this AARP study survey that took place, a lot of people are concerned about physical dependency, having to rely upon others to help meet their physical needs. They're also worried about mental deterioration, being in a great amount of pain, and not being able to communicate. So again, thinking about what are the priorities in your life and also at the end of your life, keeping those things in focus when you're talking to your loved ones about what your wishes would be, and also when your loved ones talk to you about what their wishes would be. Okay, so why is it that we continue to have this pattern of dying that's so different from what Americans truly want for themselves? So let's be honest, here in America, we never want to think that we're going to die. We are a death-defying society. We continue to always think that one way or another, death won't happen to us. And even though we know logically that that's not true. There's also this belief that science/medicine can fix anything and everything. And it cannot, unfortunately. We cannot replace every single thing that a body can do. It's just not possible. We also think about the fact that we have a very litigious nature in this country that's often a reflex that a lot of people have, especially when we're dealing with really complex situations or scary situations that people confront when dealing with medicine. When we think about the medical profession itself, there's this technological imperative to think that, unfortunately, they themselves, providers can think that medicine can fix everything, even though they know, again, that it cannot. So we tend to think that, every single problem that exists for a person can somehow be fixed by medicine. There's also this inherent problem of a stranger taking care of others. When you come into the hospital, you likely don't know anyone on your medical team. And yet we're having these strangers be in charge of your care. This is why the team often turns to family to kind of fill that gap, to tell us about their loved ones, about the patients that we're taking care of. That's always very important. And again, unfortunately, if you don't have those conversations, you can't inform the medical team about what a patient would want. And then lastly, when we look internally at ourselves, we again see that denial and superstition about the fact that we are all going to die at one point or another. And then we lack the ability to have those crucial conversations. We lack the words. And so again, this talk, we're going to try to give you those words, those tools to have those type of conversations, to be prepared, and to kind of lift that burden that people may have when dealing with these serious types of situations. Okay. So just by, again, using the chat function, has any of you spoken to a loved one about their end of life wishes? Okay, good. I'm seeing quite a few yeses. I'm glad to see that. Okay. All right, great. So as you can see, you're not outliers, but often met with denial. Yes, that's a good one. See, just like I was saying, a lot of people still deal with denial. They don't go into great detail about it. So like the folks that have had these conversations with their loved ones, the vast majority do speak to their spouse or partner about what those wishes would be. And then occasionally you have folks that are more comfortable talking with their friends, their lawyers, their primary doctors. I'm actually surprised that people might talk to their lawyer before they talk to their primary physician, but still they at least talk to someone about what those wishes would be, or some other family member, depending on how close they are, the nature of their relationship. So it does sometimes happen, but I think, like I saw a few of these, it could be vague discussions that don't really go into detail. Okay, so let's get into the nitty-gritty of this process, how to actually have this conversation. Okay, so first off, you have to start with your own self-reflection, okay? When you're thinking to yourself, just reflecting within your own soul, analyzing your own life, you have to think about what makes your life worth living. And I'll give you an illustration. I had a patient who was at the end of his life, and he said to me, at the end of the day, as long as I can drink my bourbon and eat ice cream, that's all I want out of life. If I can still enjoy those two things, I'm good with life. Now, not everyone's satisfaction with life can be that simple, but taking the time to have that self-reflection, I think, is always important for folks to at least have a starting point from there. Next, you want to think about what conditions would be unacceptable. Now, when we say conditions, or when I say conditions, I don't mean like specific diagnoses. What I mean by this is, you know, what would be important to you? Is it important to you to be able to recognize your family members when they walk through the door? Or is it important to you to not only be able to recognize them, but also to carry on a conversation with them? And if you can't do either of those things or one of those things, what then should be the next step? So again, not focusing on specific diagnoses or anything like that. It's those values, those types of relationships, things that capabilities that you would hope to preserve depending on what the medical condition might be. Also thinking about what we're willing to tolerate in order to survive. You know, in America, we like to say, oh, he or she is a fighter. And it's like, okay, but is there a stopping point to being that fighter? Within yourself, do you think you have a stopping point where you just realize that that is the line that you can't cross anymore, that you can't do more than, and when you hit that line. So once you've done that self-reflection, now you want to turn to who I should actually talk to about this. So most people turn to a family member, likely their spouse or partner, maybe their children and friends. And I want to highlight your primary care provider if you have one. It's always good to at least include them. Like, they may not influence what your decisions are, but they should at least be aware of what your decisions are. Because they are a more neutral party than a family member or friend may be. So you kind of want that neutral party to exist for you. And then lastly, once you've kind of gotten all that worked out, then you can write it down. And we will get into those documents, the living will, the durable power of attorney for healthcare. Okay. Now, once you've done the self-reflection, how do you actually have the conversation with whoever you choose to have the conversation? Maybe you don't have a family member that you feel comfortable with having a conversation, or you don't have a close friend. Maybe it is your attorney that you feel more comfortable with having a conversation with. How do you actually start the conversation? Okay. So you've already started with, I want to tell you with what I've been thinking about. Now, this can be a one-on-one conversation. This could be in the middle of Thanksgiving dinner. In fact, I think a couple of years ago, there was this drive that over the holidays that folks should really think about their healthcare decisions and making sure their family members know what their healthcare decisions or wishes would be. Just making sure that you're in a setting that you feel comfortable with and having that conversation is always key. And then dive into why this is important and why you're counting on that person to be your voice, that you have prioritized them to be the person who has access to the knowledge about what you might want for yourself. Okay. And then talk about what matters most. Being able to be at home, being able to talk with family, being able to think, being able to communicate, or for some folks, survival in any state, that as long as my heart is beating, I am okay. And for some folks, that is perfectly fine. But for others, we know that there's a variation on that continuum, that some people may not be okay with that. Now, when you are having that conversation, do not focus on specific treatments or interventions. Now, if you are knowledgeable enough to be able to list off or rattle off, specific interventions that you know absolutely you wouldn't want, then fine, you have the freedom to list them. But honestly, I think that actually ends up confusing folks if they get into that level of nitty-gritty detail when trying to have this conversation. Do not force the other person to share their feelings right away. Sometimes the reaction you get when you try to have this type of conversation with your loved one is, why are we talking about this? I don't want to even broach this topic right now. This is too heavy of a topic for us to discuss, or, I'm not ready to talk about this with you. And if that's the case, then maybe that isn't the right person for you to have that conversation with. And you find another family member who could have that you trust enough to have that conversation with. Okay. Don't forget to write it down, because unfortunately we deal with situations sometimes where the family members can't remember specifically the details that were discussed in that conversation. And so writing it down can help refresh folks' memory. And then lastly, don't forget to give copies to your provider. Okay. So the one fundamental thing in all of this is making sure that, one, you have the capacity to make this decision, that you have that you are exercising your autonomy in decision making. So what do we mean by autonomy? So as a clinical ethicist, autonomy is actually one of the founding principles of ethics in medicine. And it essentially is the principle that everyone has the right to be free of any outside influence in making their own medical decisions. And in order to exercise that right, you have to know what your choices are and be able to make those choices based upon your own personal goals and values. And in order to do that, you must be capacitated and competent. Now, we'll get into the details of what those words mean, capacitated and competent, but just keep that in mind, that the gold standard for decision-making in medicine is autonomous decision-making, and that's based upon what the known values and goals of the patient are. Now, unfortunately, if we don't know what those wishes are, or that person is unavailable to tell us what their wishes are, we would then go to the silver standard, where we have a healthcare power of attorney, a proxy, or surrogate decision-maker speak for the patient. And what their job is to do is to stand in the shoes of the patient and say what the patient would have wanted in that situation. They're supposed to make decisions based upon what they know the patient would have wanted, not based upon what they want for the patient. And this is what we call substituted judgment. And then lastly, we have the bronze standard, where if we absolutely don't know anything about what the patient's wishes would be, then we make decisions based upon what we think would be for their benefit, for their good, that would bring about the most good for that patient. That's the best interest standard. Okay. When we talk about decision-making capacity, we have 4 criteria that we're always looking at: an ability to express a choice, to understand the information that's being provided, an ability to appreciate the implications of the information and for one's own situation, and then lastly, be able to reason rationally about the decision that you're making. Now, in order to do this, it's usually a physician who's making this determination about whether or not someone has capacity. It is often the default that everyone is believed to have capacity. It's only until a patient starts making decisions that seem counterintuitive to their interest that we might start questioning what their capacity is. Now, we know that capacity is needed in order to provide or in order to respect someone's autonomy. But how do we actually know what autonomy looks like for a patient? So if we have a fully capacitated patient who's filled out their advance directive, and again, those advance directives are living will, healthcare power of attorney, the donor enrollment form, which you guys should all have copies of, and then lastly, the declaration for mental health treatment. I won't go into much detail into this last one, but it's an extra one that you guys should be aware of. These are the documents, the legal documents that allow someone, if they lose their capacity, to kind of still provide direction to their loved ones and to the medical team as to what care should be provided on their behalf. I do want to highlight the donor registry form. Everyone thinks that, oh, I was at the DMV, I chose to be an organ donor, that should be enough. Unfortunately, it's not. I have personally run into many situations where families have chosen to ignore the patient's driver's license. But if we had the donor registry enrollment form, then we would show to the family and say, look, your loved one truly wanted to donate their organs, to the point that they even filled out this document and selected which organs they would like to donate. that kind of really reinforces to the family that no, they truly did want to donate, instead of, oh, this 2-minute question that they answered while at the DMV. It just doesn't carry as much weight as most people think. Remember, all of these documents are ways to communicate wishes when a patient cannot speak for themselves. And remember, without these types of documents in place, the default is going to be do everything at all costs, and we will then use the next of kin hierarchy for these type of situations. Okay, so the healthcare power of attorney. It names a person to act as your agent, and they will make medical decisions on your behalf when you cannot. So basically, when you lose capacity, whoever you named as your healthcare power of attorney will step in to make medical decisions on your behalf. So a lot of people use healthcare power of attorney, the term, interchangeably with surrogate or proxy. Now, I'm a lawyer by training, and I'm very cognizant about the terms that we use. Healthcare power of attorney is only someone who's been appointed when the legal documents have been completed. When you have a surrogate, a proxy, or even next of kin, these are more kind of loosey-goosey terms that we use to designate someone as a potential decision maker for a patient. But none of those carry the legal weight of a healthcare power of attorney. They don't have the legal documentation to kind of back that up, that appointment as someone's decision maker. Doesn't mean that this stops them from making decisions, but healthcare power of attorney is the one that really has the legal weight. So this person can make all decisions ordinarily given to the patient, such as giving consent for treatment, refusing treatment, and they can also make end-of-life decisions as well for a patient. Okay. A patient can select anyone except their medical provider and his employees, an administrator of a nursing facility, or employees of a hospital. Outside of those folks, anyone can be elected or selected as a healthcare power of attorney. Now, this is different from a regular power of attorney. So when you're thinking about these documents, a regular power of attorney is a document that appoints someone to make financial decisions for you, versus healthcare power of attorney makes medical decisions. So you want to make sure that you're filling out the right document. Okay. This is actually something I always remind the doctors when they say, oh, someone's the POA, someone's the POA. And I said, did you actually look at the document? Because remember, there's 2 types. You often have to remind folks of that. Patients have to be capacitated when they complete this document. You do not need a lawyer to complete it. In fact, this is why we sent it out to everyone, that you could kind of pre-fill it out ahead of time. So is this the same as a dual power of attorney? So potentially. Again, you will have to look at the actual documents. You have to read them and see what the terms of appointment are to know for sure if that dual power of attorney can, has the authority to make financial decisions and medical decisions. So great question, Ms. Gardner. Okay, so for the healthcare power of attorney, it can be either signed by 2 witnesses or it could be notarized. So it was brought to my attention that folks were asking about where you could even get these documents notarized. You can go to a bank, you can go to UPS, and I believe UPS, the last time I went there, it only cost you $5 to get all of your documents notarized. It's the one-time session. They don't charge you per document. So it's a pretty nominal fee to get something notarized. But again, it's not required. You can get 2 strangers off the street to witness your signature, and they can act, and your document would be legal. The witnesses you choose, though, cannot be an attending physician, administrator of the nursing facility, or the patient's relatives, okay? That is a very important point, because if you have a family member sign as your witness, that will invalidate the form. So it would no longer have legal weight. I have another question from Ms. Eskridge. Is it more favorable to seek legal guardianship or healthcare power of attorney for a family member? That's another great question. So unfortunately, this is one that, that is very dependent upon the situation that you're dealing with. A healthcare power of attorney, if the patient has a capacity, definitely go with appointing, like having them complete the power of attorney, because getting guardianship is, one, more expensive and a longer process to go through. And honestly, it's only sought if the person at the heart of the matter has already lost capacity and likely would be deemed incompetent by a court, by a judge, okay? Another comment, many banks have notaries in the branch and do not charge customers to notarize documents. Yes, that is true. But again, you know, just in case, that's why I said banks or UPS could do this for you. But yeah, a bank could do this as well. So kind of going, no problem. Going back to that question of healthcare power of attorney or guardian. Like I was saying, for healthcare power of attorney, if the patient's capacitated, that really is your kind of easiest path to go. But unfortunately, some people, you know, if you kind of miss the boat to appoint a healthcare power of attorney, then guardianship has to be pursued in order to act on behalf of that on behalf of that loved one. And unfortunately, it is a longer process to go through. Now, getting back to the slides, the patient must discuss, in fact, I really strongly would say, whoever you appoint as your healthcare power of attorney, let them know what your wishes would be, because they can't be flying in the dark trying to make decisions on your behalf. I've had to deal with anguished children, spouses who are like, why did they choose me when they didn't even talk to me about what they would want? It is honestly a favor to them to tell them what you would want in these really complex situations, because at the end of the day, they're the ones who not only bear the brunt, but also the burden of making these decisions when they don't know what you would want in these really sometimes complex scenarios. Lastly, you want to provide a copy to anyone listed in the document and to your medical providers too. Because unfortunately, I've dealt with situations where family members have hidden the healthcare power of attorney form because they don't want other family members to exercise their authority as a POA. So again, think about giving it to a neutral party in order to avoid those kind of conflicts. Can two people be appointed? So as a joint healthcare power of attorney, I have seen that. Hopefully the two people you appoint can work well together, because if they don't, that unfortunately become very messy and result in the hospital saying to the two that's appointed, one of you go get guardianship. I've seen that situation. If you can appoint one, please appoint one. But if it has to be two, please make sure there are two folks that can work well together. So it is possible. In the Ohio forms, it doesn't allow you technically to do it, but I've seen it. People have done it before. I hope that answers your question, Ms. Dixon. Okay. All right. So what happens if you don't appoint a healthcare power of attorney? So one option I've already mentioned is to go to court, get guardianship. But like I mentioned, that's a longer process and it's more expensive. In the meantime, most providers will use this hierarchy that Ohio law does designate. Now, technically, this hierarchy only applies at the end of life, but hospitals often use it for any medical decision. And this is the hierarchy that most people think of when they say next of kin. So normally it would be your spouse who we would go to first for making a decision. But if you're not married or if you're a widow, then we would go to your adult children. If you have multiple adult children, then we will go with a majority of the adult children. Now, if you have an even number of children, like if you have two kids and they can't on the same page, again, the hospital will say, please go to court, one of you go get guardianship, because we have to have someone, you know, either they get on the same page, because the hospital won't pick between the two kids. We won't do that. The other situation that we sometimes deal with when we have an even number of children is we'll see who kind of knows the patient better. Like if they've had conversations with them, if they went with them to their doctor's appointments, if they've actually talked to them about, you know, Uncle Bob had a heart attack, and when Bob had a heart attack, mom told me this and that. Then the hospital may lean more towards one sibling over the other. But most of the time, the hospitals will just say, please go to court and sort this out. We don't want to get in the middle of this. And so if you don't have a spouse or adult children, then next will be parents. And then after parents, siblings. And again, if you have multiple siblings, we go by majority. And then if you don't have any of these above folks, then we go with any other relative that's related to you by blood or adoption. Okay. And they have to be related to you in these ways. In-laws do not count. Ohio law does not mention marriage. as a relationship. Yeah. So if you have in-laws that you would want as your decision maker, or for some reason you don't like this next of kin hierarchy, if you want your siblings to be your decision maker over your spouse, the only way that would happen is if you designate them specifically as a healthcare power of attorney. Okay. As the asterisk says, this hierarchy is strictly followed if we're dealing with end of life situations. Unfortunately, this scenario still leads to a lot of problems. I mean, to the point that it has literally torn families apart. Again, I want to emphasize appointing a designated person really does help alleviate some of the tensions that sometimes come up in these type of scenarios where we have to figure out who should be the decision maker. Okay. All right. So just continuing on with healthcare power of attorney. As usual, the general purpose is for making healthcare decisions. You can pick 2 alternates in case your first person isn't available. Let's say they're out of the country, no one can reach them, then we'll go to your alternate person. You can give the POA or HPOA authority to access your medical information at any time. They need that information sometimes to make good medical decisions on your behalf. You can also authorize your POA to withhold artificial nutrition and hydration in certain situations. And there's a section where you can nominate someone as a guardian for you. Again, this is just a nomination. The court has the final say as to who would actually be appointed as your guardian. Okay, let's move on to the living will. This is a second document that allows a patient to dictate what they would want at the end of their life. And I want to emphasize at the end of their life. If you were just coming in for a car crash and you don't have life-threatening injuries, your living will would not apply. Now, if you had terminal cancer, then it would apply. So if you had terminal cancer, or if you were in a permanently unconscious state, such as a vegetative state, let's say you had a traumatic brain injury, or you were in a persistent coma, those are the times that the living will would be looked to. These are the times that the medical team will say, we'll look at this document and say, okay, what would the patient want in this situation? Would they want to continue with the ventilator? Would they want a feeding tube? Things along those lines. These forms are purposely very general because, again, you know, no one can predict what their potential medical issue would be in the future. And so, again, this is why I was saying earlier in the talk that you don't want to focus on specific medical diagnoses or procedures or treatments because you just don't know what they might be. It does allow you to choose non-aggressive care, to forego non-life sustaining treatments, or to go ahead and get them too. It's either or. You can write specific instructions. For example, someone has, like I had a patient who wrote, if I'm terminal, I'm okay with being intubated for 3 days so the family can say their goodbyes, and then to terminally extubate me after 3 days. It can be that specific. But again, I kind of hesitate for people to be that specific because you never know what the scenario may be. And allows you to forego artificial feeding if you're in a persistent vegetative state as well. It is not the same as a DNR. And we'll get into what a DNR is. But it certainly informs the healthcare surrogate and the physicians as to deciding co-status and other aspects of the treatment plan. Okay. It also provides you a list of next of kin who should be notified in case you're dying. And that's different from decision making. The folks you list there are only notified. It doesn't grant them authority to make medical decisions. It also allows you to make organ donation selections, which is optional. The living will trumps the healthcare power of attorney. So if you have a living will where you specifically said, if I'm terminal, I would not want a feeding tube, and then you have a healthcare power of attorney saying, no, I want the feeding tube placed, the medical team would say to the healthcare power of attorney, I'm sorry, but the patient has already made a decision for themselves. They would not want a feeding tube. We would honor the refusal that's in the living will over what the healthcare power of attorney is saying. It is very rare for us to deviate from that because, again, reminding you guys earlier about the decision-making standards. the healthcare power of attorney is supposed to stand in the shoes of the patient and make decisions that the patient would have wanted for themselves. So they've already made the choice and it's in their living will. We're not going to turn back to the POA and say, make this decision. Both documents, both the living will and healthcare power of attorney, are valid and binding until revoked or updated. And it's easily revoked or updated. You can just tear it up, burn it, write revoked across it. There's nothing really like special about revoking either of these documents. Ohio law does require compliance of the medical team, not the family. And so, like I was saying before, if a healthcare power of attorney tries to trump the living will, the healthcare team could be held liable if we ignore the living will and go with what the healthcare power of attorney says. We would be in trouble if we did that. The medical team can also refuse to provide non-beneficial treatment no matter what the living will states. This only comes up in really, really extreme situations where the situation is likely one where the patient is going to die no matter what the medical team does. And at that point, the medical team is trying their best not to harm the patient by doing more to them. That's not going to benefit them. Again, only in extreme situations and rarely comes up. Okay. Just some general ideas when you're thinking about the living will. Keep in mind that modern medicine is active and aggressive. They're going to keep going until someone says stop. And again, if you know what your personal wishes and values are, you should definitely say what your stopping point would be. Having a living will won't change that except at the very end when it will no longer help. This is your way to let people know what you will tolerate and what your end line is, what you won't tolerate. And these are things like long-term support, if you have a neurological disability, or if you end up in a totally dependent state. And just, again, thinking about what you would like your last days, weeks, months to look like. So talk to your family and write some specifics in these documents. Okay. Again, tends to be some overlap when you're looking at these documents. Both the living will and the durable power of attorney for healthcare both list sections where you can choose to limit what type of treatments you would not want. And these are both oral or written expressions of what an adult decision maker would want for themselves. And keep in mind, it's the patient, not the family, who can revoke these documents at any time. Okay, a healthcare power of attorney can't say, I revoke a patient's living will. They can't do that. And again, I want to emphasize having that discussion with the family member so they're not surprised. Unfortunately, I've seen that too, where family members end up surprised by what's in the living will. Let them know it is not best to keep these things secret, especially at such a stressful time in people's lives. Okay, so let's get to the actual documents. I'm gonna stop this slideshow and get to the actual documents themselves. Okay. Now, have you guys had a chance to look over the documents? And you can use the chat function to let me know if you have had a chance to look at some of them. Okay, yes, great. Okay, so let's start off from the top. All right, so the healthcare power of attorney / living will declaration. Okay, so this is just a checkbox letting folks know, folks being the medical team, what documents you have completed and which ones you have not. It's up to you if you choose to fill this out or not. This next page just tells us who this power of attorney is for, who the patient is. And then this next section is just definitions to make sure whoever's filling it out knows what the applicable issues or topics may be that or terms maybe that's listed in the document itself. I'm not going to get into that. You guys can read that on your own. Okay, let's get to page 3. All right, so this is where you actually name who you want to act as your healthcare power of attorney. Clearly list their name and their relationship to you, their address, and their phone number. And I would say if they have multiple phone numbers, write them all down just in case, because sometimes we've had situations where we can't get in touch with them because their phone number's been disconnected or they've moved or something like that. So it's best to kind of put as much information as you can for who you want to act as your decision maker. Okay. Next, you want to place your initial in this box to allow your healthcare power of attorney to have access to your medical information, your medical records, so they can make medical decisions on your behalf. Okay. Stop me if you guys have any questions. Again, use the chat function. I'm keeping an eye on it. So if you have any questions, please just jump in there. All right. This next section is where you can list alternate agents. So alternative people in case your primary healthcare power of attorney is not available, who you wouldn't mind stepping up to the plate to make medical decisions on your behalf. If you don't have anyone, then I definitely would say put an X through it, because you don't want someone else coming along and putting in their name for some reason. I have seen that happen where random people have done that. So if you don't have anyone else, please use that X. All right, this next section tells you what authority your agent has. Kind of lists out all the decisions they could possibly make for you. Okay, I have a question. Is there a card that can be carried to let others know, i.e. hospital, that you have a healthcare power of attorney or living will? So unfortunately, UH does not have one. At one point, I think CCF has one. I know they definitely have it in their, in my chart, where you can have it listed there. I've also seen some folks, they will scan the document using, okay, the easiest example is your vaccination card. There's a scanning feature that you can use to scan your vaccination card. You can kind of use the same feature to scan the important parts of this document too, so that people know that you have a healthcare power of attorney. Unfortunately, Ohio does not have a standard card, wallet card that that people can walk around with. You can just have it listed in your documents in your phone. I wish Ohio did have one, but they don't. Okay. All right. Let's move on to this next section. All right. So these are the special instructions, and if you choose to place your initial in this box here, you're choosing to refuse any artificial technology that would provide you with nutrition and hydration. These are things like a DOPOP, an NG, a PEG tube, or TPN, so getting nutrition through an IV. Often people will choose to place these, or choose to refuse these types of interventions, because if they're at the end of their life, they know that artificial nutrition and hydration can end up prolonging their dying process, and actually does not end up helping them. Because unfortunately, at the end of life, your body starts shutting down and no longer processes the nutrition and hydration. So it could actually end up being detrimental to you. So some people choose to forego that. Okay. The one caveat to this is if you were pregnant, that this may be ignored. That's the one little like chink in this. If you're pregnant, they oh great, thanks Kalia. Providing a link to the document again in case folks don't have it. So if you're pregnant, and this is number 2, in order to sustain that pregnancy, they may choose to ignore this refusal. Next, we have this box where you can list special instructions as it relates to the artificial nutrition and hydration, or any other treatment that you may want or may not want, that you can list those here. Okay. On the next page, page 7, you have nomination of, I'm sorry, page 6, you have nomination of the guardian. This is basically where you get to tell the court, if for some reason the court deems you to be incompetent, the court will look at this document and say, okay, this is someone that could possibly step in to act as your guardian. This first section is guardian of person, and the guardian of person is responsible for making your wellness decisions, things about your health, making sure you have food and clothing, things about your general wellness. Okay. And this is the section where you fill out who you would want to nominate as your guardian of person. All right, and again, if you're not going to use it, please put an X through that section. All right, this next section is guardian of estate, and the guardian of estate is responsible for making financial decisions on your behalf. And again, you could nominate who you would like. Okay, I have another question. Are there any advocates that can help people go through these documents? I think outside of the hospital, you can definitely go through these documents with your healthcare provider. Your primary care provider can definitely help you. If you are in the hospital, often social work sometimes helps you. Sometimes ethics can help. So it's really, it depends on where you are in your healthcare, but there generally is someone available to help you fill out these documents if you need. Another question, with guardian of estate, does that include access to bank accounts? Yes, it does. It definitely does. They would need access in order to make those financial decisions on your behalf. And in fact, because they have access to your bank accounts, that's why they have this next section about bonding. Because unfortunately, we've had guardians who act inappropriately as a guardian and steal people's money. So you can elect for your guardian to waive bond, meaning that if for some reason they choose to use your funds inappropriately, then they don't have to reimburse you. But if you don't want to waive your election for them to be bonded, you can leave that box unchecked. Okay. All right, next. Okay, see another question. Life insurance companies can offer as a service. Yes, it can. And the service being bonding on behalf of the guardian of estate. So thank you for putting that in, Ms. Rosier. All right, on this next page, we have the signature of the principal. So if you have completed this form, I hope that you left it unsigned, because when you go to either the notary or the witnesses, they're witnessing your signature, not witness you filling out the document, okay? They are basically witnessing that you are who you say you are when you're filling out or when you're signing this form, and that you are of sound mind when you filled out this form. So that's what they're witnessing, not any of the details of what's in the actual document. All right, and this is a reminder of who cannot act as your witness for this document. And so these are the two sections for either the witnesses or for the notary at the bottom here. And remember, you don't have to have both, it's either or. Okay, next question. Does that guardian of estate with finances end up upon death? No, the guardian does not automatically get your money at the end when you die. It is not. If you have a will, whatever properties or finances are available upon death, the will be followed. And if you don't have a will, and then this is a regular will, not a living will, then you will go through probate, and the probate will divide up your assets, okay? All right. Now, these last couple pages are just notices to the person executing this document. Again, more formal instructions as to what you should do. It's basically going over what I've just told you through this talk and through going through the document itself. All right, now we get to the living will. This again, this first page is just a notice of declaration, basically reminding you what document you are completing, and that it's only applicable to individuals who are in a terminal condition or a permanently unconscious state, okay? And you, of course, have to have a physician who makes a determination, okay? Again, you start off with, who is this document for? And then it goes into the same definitions as earlier, as on the healthcare power of attorney. And then on this third page, this is where you get to list who the medical team should contact, not who will be making decisions for you, but who should be notified, okay? You can also complete or check this box up here if you have a healthcare power of attorney, if you completed that document, so they know that you have a separate healthcare power of attorney who will be stepping in to make decisions on your behalf. So here you get to list who should be contacted. And again, you have the option of listing 3 people. And they have the same box here that if you are in a terminal state or permanently unconscious, you get to refuse, by putting your initials in this box, you get to refuse the provision of artificial technology that would supply you with nutrition and hydration, okay? And again, you have this box available to you to list specific instructions that you may have, okay? This next page is where you get to pick and choose, if you want to be an organ donor, which organs you would feel comfortable with donating, and also the purpose for which those organs should be used. Okay, so you can specifically say transplantation. And let me say for myself, I am a part of our transplant program. That transplantation is a wonderful program. It's really a true gift. And keep in mind, again, this only is applicable if you are at the end of life. That's it. Unfortunately, I've seen situations where families try to overrule a person's decision to be an organ donor. And if you have completed this document, the medical team has a stronger ability to say to the family, no, this person really wanted to give this gift to another person, that they truly did want to act as a donor. And this wasn't some quick decision they made at the DMV. So I really want to emphasize, if you want to be an organ donor, please complete this section. And again, you have the ability to sign the living will. And keep in mind, only sign once you have your witnesses in place or you have your notary. Okay. All right. This is a fuller donor registration enrollment form. And again, giving you the instructions for further enrollment form and where you should send your send this document to once you've completed it. The living will and healthcare power of attorney you keep. If you complete this enrollment form, you do have to send it to this address, and this formalizes your selections as an organ donor. Okay, and that's it for these 3 documents. I remember I did mention earlier that there was Ohio form for mental health treatment. This I'm only going to go over very briefly. This is for folks who knows that they have an underlying psychiatric diagnosis. And this form allows you to designate which physician you want to be your treating physician. You can also determine or list which medications you want, which medications you don't want, which treatments you would be okay with, including ECT. You can also designate, if you need a mental health facility, which facility you'd be okay with going to. So this is a lot more detailed than the general healthcare power of attorney or living will. Okay, and again, you can talk about your treatment preferences as well in this document. Okay, so I'm gonna stop sharing the documents for now and jump back to the presentation. All right, any questions, any other questions from the documents themselves? Okay, where do you specify your election for a tissue donation? Okay, so let me jump back to that document. Okay, so you can designate it in 2 places, one being on this enrollment form that you can select which tissue you want to select, or you can have it make those selections in the living will. And this is page 6 for your anatomical gift section that you can list again which tissue you would want to donate. Okay. All right, any other questions for the documents themselves? I know I went through this really quickly. Again, if you have more detailed questions, definitely speak to your healthcare provider about it. They can go into a lot more detail with you. I don't know, Clea, if you're sharing my personal information, I would not mind if you guys wanted to reach out to me, and I can specifically answer any specific questions you may have about the documents and how it pertains to your specific situation as well. Okay. So I want to end with these other documents that you may see. These go over code status. This is the outpatient DNR order form that exists here in the state of Ohio. Unfortunately, some people mix this document up with the living will or healthcare power of attorney. In the healthcare power of attorney and in the living will, you can say you don't want to be resuscitated, but honestly, the official forms that allow you to forego resuscitation in an outpatient setting can only be officially done if these forms are completed. And these forms are only completed by your physician. It is not completed by you. That's the key difference between the DNR Comfort Care Order and the Healthcare Power of Attorney and the Living Will. Okay. As you can see here, you have two different types of co-statuses. You have DNR-CC, which is DNR Comfort Care, and it is activated immediately. And so what it means is that once this form is completed, if your condition were to deteriorate to the point that you were to arrest, so your heart were to stop or you were to stop breathing, you would not be resuscitated. And also, as soon as this form is signed, your goals of care will be shifted to only providing treatment that has the goal of keeping you comfortable. That's it. Now, on this page, it lists the resuscitation protocol. Some folks will even list, some physicians will even list what measures would be provided in order to keep you comfortable, such as oxygen, ice chips, antibiotics. It's very dependent on what your specific clinical situation is. And so it'd be up to the providers to determine what medications should be given in order to keep you comfortable and what other treatments should be given as well, again, with the goal of keeping you comfortable. Now, if instead of DNR-CC, if that's not checked, but DNR-CC arrest is checked, this basically means that comfort care, the comfort care protocol will only take place when a cardiac arrest or respiratory arrest takes place, okay? So that's the key difference. It's the timing of when comfort care would start. But if for any of these, if you were to arrest, a respiratory arrest or cardiac arrest, you would not be resuscitated. And then lastly, you have this, this last one, the straight do not resuscitate order. That is, again, if you were to have your heart stop or your breathing to stop, you would not be resuscitated. And it doesn't go into the comfort care protocol at all, okay? The physician also has the option of checking the box that you have a living will as well, so that the paramedics or your family know that you have these other set of documents that, that list your preferences, okay? Now, sometimes folks get a little confused because the terminology isn't exactly the same going from inpatient to outpatient, but they're still very similar. So inpatient, you have do not resuscitate. You also have do not resuscitate comfort care. And these are essentially the same as what we have on the outpatient basis, which is DNR comfort care arrest and DNR comfort, do not resuscitate comfort care, okay? I'm not gonna get into the nitty gritty of what the full differences are, but just kind of keep those general terms in your mind. Okay, so when are these orders placed? Often during a discussion with the patient and their provider, when the provider or patient believes that resuscitation would not be beneficial to the patient. Now, these often only come up when the patient is terminal. This is not something, again, if you were just in a car accident, no one's going to be talking to you about your co-status unless it's a really, really, really bad car accident. That's just really a one-off example of that. Usually it comes up if you have a terminal cancer diagnosis or if you have a major stroke that co-status may be discussed. When there's, and so it's only brought up when there's a medical indication that resuscitation would not be beneficial. It does not come up in general everyday medical care. They can be ordered for any adult, whether or not they are in the hospital, okay? Again, you can have it inpatient or outpatient. Doesn't really matter where you are. You could have one in place. And then lastly, I wanted to highlight the differences between palliative care and hospice. People often kind of think of them interchangeably, when honestly, hospice kind of fits within palliative care. So palliative care in general provides supportive care that can treat symptoms of disease or treatment. So you can continue with any curative treatment that you want, and any symptoms you have from that treatment is what palliative care tries to treat, okay? Now, unfortunately, if your disease process progresses to the point that curative treatment is no longer an option, then you shift to hospice. And in that treatment course, you focus on comfort at the end of life. It provides support not only to the patient, and I want to emphasize this, it also provides support to the family. through their grieving process. It's an invaluable service at the end of life that I really think that people don't know enough about. Care can be provided in any setting, in the home, your own personal home, in a nursing facility, or in a hospice unit, depending on what your clinical status is. Okay. All right. So are there any last questions? I think I've almost finished our full amount of time. We've definitely gone over the hour. Are there any last questions that folks may have for me? Oh, thank you, Ms. Walker. I appreciate that. All right, if there aren't any other questions, then we are done. And I want to thank you all so much for your time and attention on this. I really do think that it's honestly, and this may sound cheesy, but it is a gift to your family to have these discussions. Like, I can't emphasize enough, or how many times I've seen how very hard this can be for families when they haven't had the time to think and talk with each other about what they value. It really is important. And I know these discussions are not easy, but they need to be, they need to happen. And no one is too young to think about these things. I teach, young college students. I have 20-year-olds who I have complete their advanced directives. At any point in time, as soon as you turn 18, I even have some young adult, adolescent patients, unfortunately, who have to think about these things. And I encourage them to write down what their wishes would be. It really is helpful to kind of have this out in the open, that there's no surprises when these difficult situations arise. I mean, I can personally tell you, families can end up with PTSD carrying around the weight of having to make these decisions if they don't know what people would want for themselves. So can't say enough how important it is. So thank you all so much again. I'm seeing all the thank yous. I thank you so much, everyone, for your attention for this. And I see one last question. Are there resources to assist those appointed as POA or surrogates make those tough decisions, and post resources to those who have? If your loved one is in the hospital already, there are plenty of services. There's palliative care, there's ethics, there's social work, there's spiritual care. Oh, don't even, like, spiritual care really can be extremely helpful in these types of situations to not only help support families through making these decisions. And in fact, sometimes we recognize some people just can't carry that weight of making that decision. They need someone else to kind of step in to help them with making that decision. And sometimes we do that because we know, again, the weight that carries. So you can definitely do that. Can a healthcare power of attorney execute a DNR? They can, again, in only very specific situations. And they can do it inpatient or outpatient. Again, even with the healthcare power of attorney doing it, it's only applicable, or we will only institute it or execute it if it is determined to be non-beneficial to the patient, that we would do that at the behest of a healthcare power of attorney. All right.
Oh, Mary, thank you so very much for all the information that you shared in a very short period of time. I see the question still requesting your contact information. If it's okay with you, we will email out again a copy of the State of Ohio Advanced Directives. If we can share your PowerPoint, we'll send that out as well. And then whichever email address you want me to use to share, just let me know, and we'll send this back out to everybody tomorrow. Okay.
No problem at all. Oh, I see. Sorry, I saw one more question. I think this one is from you, Khalida. When is the best time to put these documents in place? Now. There's no time like now. Yeah.
All right. Well, thank you, everybody, for your time and attention. And we'll follow up with the information that was shared through the email that you registered with. Have a good night, everybody.
Thank you. Have a good night. Bye-bye, everyone.